thank you. Thank you for having me here today. I'm really excited to talk about data science and the exposome. I don't think I'm going to talk about anything that Roz set me up for, so I will try to interject some of those as we go. So the first big message of my talk today is that data science is a team sport. It is not just some nerdy people at their computers taking your data and making magic. It really requires everyone, all of the people in this room, in our community, to provide the context that we've heard about. I have been so fortunate to work with some really great people who are all up on this slide. Also go Yankees. Okay, so when we think about the exposome in data science, it is a very buzzy title, right? When I think about the exposome, I really think about it in all of its messy glory, knowing that I can't measure everything, but at least thinking about it and conceptualizing where is my main interest within this grand scheme, or am I really trying to understand this collective exposure that a community or a person is experiencing? And so when I think about that, I basically get a headache because I think about all of that data. And I then ask myself, well, can data science help us navigate this? If you ask a statistician, can data science help? They will talk about very fancy models and mixtures methods. If you ask a computer scientist, can data science help? They'll talk about ontologies and data standards. And that also is how I think about data science, is the collective, right? Probably because I'm none of those things. I'm an epidemiologist. I think about it as this intersection, and this is a very popular diagram about data science, talking about it as the intersection of math and statistics, computer science, and substantive knowledge. And these people in the middle are hard to find. And so this diagram called them unicorns. I had a whole thing when I was a postdoc at Mount Sinai about my quest to become a unicorn. And I am much more humble now and recognize that the unicorns are not people, they are teams. They are teams that learn how to speak to each other and across these different circles. And so when we're talking about data science, that's what I'm talking about. So lucky you, you're going to get 3 talks for the price of 1 when we think about data science and the exposome and this sort of team approach. First, I'm going to be talking about making data fair. This is a big topic of interest for a lot of people. Second, I'm going to talk about how we can use data science to build data resources, what's been done and what is sort of coming in the future. And then the last part, I'm going to talk about opportunities and challenges with a specific focus on health equity. So first, making data fair. You probably, everyone has had to have heard about FAIR at this point, right? We're trying to make our data and our resources findable, accessible, interoperable, and reusable. And this is new for many of us, right? We're thinking about having our data in our own boutique little space, but now we want it to be used by others. And so we're going through this process of FAIRification. At the same time, as we collect new data, we want to keep these things in the back of our mind so that we don't go through this process again, right, of collecting a lot of data and then thinking about how do we make it fair. We want to do it at the start. But what does FAIR mean? So we do a lot of this in HHEAR, the Human Health Exposure Analysis resource, because we're taking data from a variety of studies with no prior coordination and trying to get them to be harmonizable with each other. And naturally, then, that requires us to address lots of different aspects of FAIR. And so on this slide, I just talk about the different ways within HHEAR that we have worked to make our data fair, right? We use DOI indices so people can find the data. Everything is mapped to standard ontologies. It's accessible. It's meant to be reusable. So we have code books that are very clear and never change. And this is the point where usually I talk about HHEAR ontology and why it's so great, or our knowledge graph and why it's so great. But probably some of you have heard me give that talk. And so today I'm going to go a little bit bigger than that and think about beyond HHEAR, for the broader community, how do we think about making our data fair? So I'm going to ask for a little bit of interaction. You've all hopefully just had some coffee, so you're ready for this. How many people have had a data set with more than 100 variables in there? 100 unique variables. How many people have worked with a data set with more than 500 variables? Okay, I look around, there's lots of hands up. 1,000. So all the omics people, this is all the omics you're going to get in this whole talk, but, right? So a lot of you, so we're all working with really big data sets. Think about your data set. If you had to give it to another person, is there enough metadata for them to understand what that data set is? Is there enough information there that they could judge whether it's comparable to what they have? Most of us would say, no, we're not close. And that's just the human readable part. What about machine readable? We want the computers to work for us. Why? Why do we care about verification? Because we want the future that we're promised. We want to say, hey Siri, give me all of the existing data on phthalates measured in prepubertal girls from NIH studies since 2001. That's what we want in our NIH data ecosystem. That's what we're building towards. But we'll only get there if our data are fair and we use what has been brought up before, common language. And so this is where I'm going to do a little plug for an NIEHS initiative that I'm a part of called the Environmental Health Language Collaborative. This group is focused on helping us develop a language. And again, it's not just 5 people sitting in a room. It truly depends on the community. Whether you consider yourself a data scientist or not, right? Everyone knows their aspect, their piece of the pie. And we need that in order to get at a common language. So I want to also thank Stephanie Holmgren for providing me with these slides. The ELK, as it's called, has 3 main goals: to develop language-based solutions, to implement those solutions, and to advocate the value of language throughout the environmental health community. And it does this through use cases. So if you want to take a picture of this slide, but it's all also available on the website, there are 4 different use cases. So there's something for everyone, thinking about how we can develop language. And we all have upcoming meetings. But also you can get involved in other ways. And again, this isn't just about people who call themselves data scientists deciding this is the term we're going to use, this is the ontology we're going to use. It really needs everyone. Because again, we all have our perspectives and they're all needed in these types of efforts. So that's fair. Now I'm going to talk about once our data are fair, we can start using data science to build data resources. And I'm just going to talk about a few different examples. First, we've been doing this for a while, right? This is from a paper in JAMIA about N3C, which is the National Cohort, National COVID Collaborative. Clinical data has been using standard ontologies and standard formats for a while now, right, in order to draw resources. The ability to use those types of big data sets, right, that harmonize electronic health record data across lots of different hospitals provides a lot of power. Where they haven't been so great is in incorporating any type of environmental information or also social determinants of health. But we can work with that. So a study that I am leading, it's funded by the Health Effects Institute. I mean, talk about a team of unicorns. The people I work with on this study are amazing. Uses harmonized electronic health record data here in New York City, combines it to look at whether air pollution and the downstream effects of structural racism combine together to contribute to the disparities we've seen here in New York City. And what we've done, how we've been able to do this, is by leveraging this existing data, this harmonized electronic health record data. So if anyone has ever tried to use electronic health record data from an institution, it is messy. It is overwhelming. They've done a lot of that work by using, their common ontologies and their common data formats. So we have data from these 5 different institutions. Because they have zip code, and I'll talk about sort of the benefits and limitations of that later, we can link in measures of the external exposome. So we can look at air pollution, green space, and also, again, these downstream effects of structural racism as measured by census and other variables. And so this is the study that we're working on now. It's not just environmental epidemiologists, it is also clinicians, and it is also social epidemiologists. Again, this idea that we need more holistic teams. Now, so that's clinical data. There are a lot of collective research initiatives. They're all using data science tools to try to harmonize their data. This is also being done with public health registries. This is a really interesting study out of Brazil, where because they had common data across all the municipalities, they could use machine learning techniques to predict over or underachieving on life expectancy. Think about that. At an area level, you can find a community that is doing better than expected. And then you can find a community that's doing worse than expected. And now you can dig in what's going on there. To me, this is a really beautiful, and it's a brief report, so it's short. I encourage everyone to read it. But one thing that has gotten less attention is entity resolution and the tools that are there that are available for that. So by entity resolution, I mean I have two different data sets, and I have a person who's in both. And I want to identify that person and link that data and integrate it so I get a fuller picture of that person. This is very time-consuming and very tedious work, and data science can make it easier. I've been very fortunate to work with a linked data set at the New York City Health Department that links birth, death, lead monitoring, early intervention, and school health records for a total of 200,000 children in New York City. And we then, because they're census tracked at delivery, were able to link in measures of the external exposome. So I'm not going to talk a lot about the computational methods to disentangle mixtures. What I am going to talk about is this is an example of an analysis that we're doing of trying to use machine learning tools to disentangle the multiple air toxics. But context matters. Not only are air toxics correlated with each other, but they spatially vary with other drivers of school outcomes. So what we did was we just, very simple, stratified by the neighborhood deprivation index. It's also called the Messer index. It's principal component analysis applied to census variables. And we just said, let's use our mixtures approach within these two strata. And we have a comparison to randomness to see if this is more than just noise. And what we see is that we get different mixtures in these areas. And the previous speakers and people who have asked questions have all pointed this out. The exposome that you're exposed to, right, that you're exposed to will vary based on other things. And this social part is important, not just for interventions at the individual level, but mitigation, not just intervention. And so to me, this idea of looking at the mixtures of mixtures, this is really a simple way, right? We use principal components analysis and we stratify, we look at the mixture within. But at least it's a first step. And again, all of this is, data science. But the second part, and this has also come up earlier, the if you build it, they will come idea. If you build these really large exposome data resources, you can do better regular research. So this is an example of work I did with the New York City Health Department, where we took that big data set and we used it to answer a really important question. Do children who are exposed to lead benefit from early intervention? What we were able to do is take a cohort of lead-exposed children. Then, because we had such breadth and depth of data, we could use propensity score methods to find exchangeable groups, right, to deal with this issue of confounding. And then see, did the kids who got early intervention services do better on their third grade test scores than the kids who didn't? And this figure here shows that children no matter how we defined exposed, whether 4, 5, or 10, you see that we're always, for those who care about statistical significance, we're always, to the right of that one line, where the children who got early intervention were, the children who didn't get early intervention had higher, the children who got early intervention had higher incidence ratios of meeting test-based standards than other children. So this is in JAMA Pediatrics. There was a really nice editorial about, why we should do this type of work that informs policy. This was made available because we had this really big resource. So I think as we build our exposome resources, we should do that knowing that the downstream consequences are that we can do more meaningful causal inference work as well. So opportunities and challenges that I think are specific to health equity. We often talk about that we need accessible data on the external exposome. And so we think about, well, do we have adequate spatial or temporal resolution? But how often do we ask ourselves, do we have the understanding of the historical context that led to these exposures, right? So as an environmental epidemiologist, I'm not trained in this, which is why I work with social epidemiologists, right? I would never go into somebody else's lab, or anyone who has a lab, since I don't, right, and start playing around with all of their test tubes. But I think that there's this idea that for the social exposures, as long as you have access to census data, anyone can do it. And I don't think, it isn't the case, right? So we need to start thinking about broadening our community to those people who can truly help us understand that full breadth of the exposome, including not just these social features at the individual level, but the historical context that led to them. The second thing I think we don't ask ourselves enough, until Bob did it in his talk, so he kind of ruined it for me, is can we link our external measures of exposure to our biomarkers to get this full picture? When we start at the biomarker, right, it's all at the individual level. Even though in our heads we know maybe that there's this external exposure that's causing that biomarker. But when we leave that out of the picture, we're only getting at part of this pathway. And so then when it comes to this idea of intervention versus mitigation, we've set ourselves up to focus on individual intervention and not mitigation. And so again, this idea of we need better information on the external exposome for our data science efforts, but we also need to ask the questions that most benefit from having that data available. The second, I think, challenge is we really need access to data on large, diverse populations, and that includes biomarkers of exposure. We have lots of small cohorts, but very few large ones that possess this type of data. As we've mentioned before, harmonization is really stymied by a lack of vocabulary, and that is very true among the social determinants of health, where there has been very little, at least, and I will say this very humbly, very little work that I'm aware of and that I can find about how to think about how we harmonize how different people have measured these social determinants. We can go to the idea of using electronic health records, but again, there is this limited social determinants of health. It can be, there are some limitations for the geographic data, and it doesn't always include everyone. So I'm going to show you this very crude map. You know, when you start out working on a data set, I was always taught, look at your data, right? So all I did was I just plotted the location of the COVID patients in our reach out study. Where in New York City are they coming from? That's it. That's all this is counts. And on the right is the geographic location of all cases as a rate. All I really wanted to do was see, where are we pulling from? Are we pulling from the places where we had the most COVID in New York City? And these are both the same time periods, the initial phase, right? March to June. You will see we are missing huge parts of the city. And the parts we are missing are Staten Island and Eastern Queens. Where was COVID worst? Staten Island and Eastern Queens, right? Why are we missing them? Because the hospitals that are in Insight don't cover these areas. It's not, it's not done on purpose, but think that this repository isn't just used for COVID, it's used to study all kinds of health outcomes, and there are people missing. Now, in our study, we've reached out to one of the public hospitals to get data so we can compare the difference. But I want to, as we build these data science tools, we have to think about who are we including and who are we not. This is the largest clinical research network, data network, in the country, this one in New York City. And we're missing huge parts of the population. The second thing is zip codes. I mean, I know what zip code I live in, but it's not really my neighborhood. And when we think about the unit, right, of geographic analysis that we have in some of these records, some hospitals have lat long. Some hospitals have address, but they're just not geocoded. But in these big repositories, we use zip code to protect privacy, which is important. And I'm going to talk about sort of data sovereignty in a minute. But this idea that now we're limited on our spatial resolution for air pollution greatly limits our research. Is there a better way for us to protect privacy and at the same time have more spatially resolved measures that are not just zip code? And maybe that are closer to how people envision their neighborhoods and where they move. Okay, the second limitation, I'm always nervous talking about this one as an untenured person at an R1 institution, but when we think about having these very big data resources, we have to ask the question of who has access to them. So we know that there is not equal access to NIH funding. In 2019, in a PNAS study, just 2% of NIH-supported institutions get about 53% of all of the research project grant dollars, okay? So what are the consequences of that? Some people have more research data than others. And I have always been at an R1 institution from undergrad, so this is definitely something that I have experienced. I've never not been able to find data. Access to collaboration is often limited to prior networks, and that also influences the types of questions that get asked. And so we really have to think about, if data is power, which we all would believe it is, how do we start ensuring that we start distributing that power in a way that's a little bit more equitable? I would argue that making data fair is one step towards this. By making data available to others who maybe didn't collect it but can then use it, you can open up opportunities. And I'm just going to show one example of this. I have a doctoral student, or I had it, she didn't really work with me. She sort of worked with me on the side. She was a brilliant doctoral student. She wanted to use a very fancy mixture method in her dissertation, LKMR. That's not really the point of this slide. The point was she came to me because she wanted some data before she could access her dissertation data. Now, I was an assistant professor for about a year, and I didn't have mixtures over critical windows, but I did work on the HHEAR data center. So I said, go use this publicly available resource. She took data from the HHEAR data repository, just like any of you can, and taught. She said, okay, I'm going to work on this. And then we went over the LKMR code together, and that's how she learned it. She now works at a very fancy pharmaceutical company, and she is doing very, very well. She has written a paper, and I still need to read it so that it can get published. But the idea is we were able to use this HHEAR data for training, even though she didn't have access to any of that data. That, to me, was like, this is one thing that we can do within HHEAR, and so we have. And one of the things we're doing that we've committed to by the end of this year is increasing the number of videos on how to use our repository to pull customized data sets, creating sample code to facilitate pooling. I'm actually working with some, thanks to Susan, providing her permission, some undergraduate students through a program at Columbia who are creating code that can then be posted and used by others. And finally, we anticipate having a teaching data set with applications of common mixture methods available as a resource from the data that's there. That's just HHEAR, that's one thing. But as we think about creating our tools, we do need to be thinking about, if we want to use the exposome to bring about health equity, this is one of the ways we can use data science, is by making our tools more available. Okay, and so the last challenge I have on this slide is this question of ethics. So obviously I work in the HHEAR data center as part of my work. I'm all about data science translation, but I also believe in data sovereignty. Communities have a right to own their own data. And so and this is a growing trend, right? It's not just if you work with tribal groups, more and more communities are saying we want data sovereignty. We want to own our data. More and more patient groups are talking about this. And so we as a community in this age of data science and having all of this data on people have to think, well, how do we do this? How do we balance these things? There are tools. So for example, in ECHO, I'm part of an OIF project where there is air pollution measurements, right, for all of the participants. But they don't want to share their geocodes. So someone developed this Docker where you can, a program within a Docker, so that you can submit, you can get your air pollution measurements out, everything else is de-identified, and that's how it works, right? And no one needs to share that data. There is the technology, and we probably need a little bit more, but we can do that. Like, we're smart people, right? We can figure this out, but we at least have to be thinking about it and not just making it a conflict of, well, I don't want you to own your data, but okay, if you own your data, how can I use it in a way that respects that sovereignty, but is still getting what we need out of it? So these are some challenges and meant to be thought-provoking and sort of, hopefully you have some comments at the end. So my take-home message, besides data science as a team sport, is there's a lot of potential to use data science for the exposome, specifically to contribute to health equity research, but we have to address quite a number of challenges. I think if I had to think of like recommendations or a sort of a call to action to the group, one I would think about is improving our systems, right? So how do we get more social determinants of health in electronic health record data? How do we get them to have codes for measuring metals so that way it's easier to translate that type of data for clinical use? Of course, always advancing our research methods and approaches, but finally to sort of learn from others. That group, project, that reach out group, the work I've been able to do by listening to social epidemiologists, to people who have the contextual knowledge, I just could never replicate that on my own, no matter how well-meaning or how much I want to. And so I really think the key to data science is not just looking to our computational people, but also broadening out to people who have expertise in all aspects of the exposome and really bringing them in. So I'm going to end there, and thank you very much for your time.